Hello friends, welcome to my YouTube channel. Today we are going to discuss about bariatric surgery. Bariatric surgery is a surgery done in patients with extreme obesity to decrease the weight of the patient. It also decreases metabolic complications present in a patient with metabolic comorbidities like type 2 diabetes and hypertension, etc. So this is a metabolic surgery. It can be done in any patients within the age of 16 to 65 years of age. So let's know about the indications of bariatric surgery. It is done if the BMI is more than or equal to 40 or BMI more than or equal to 35 with comorbidities like uncontrolled type 2 diabetes, uncontrolled hypertension, sleep apnea, and osteoarthritis. It can also be done in patients with BMI more than or equal to 30 with early onset type 2 diabetes. Early onset in the sense within 10 years of diagnosis. And in Asian patients, it is done at lower BMI rates because Asians encounter type 2 diabetes, hypertension, and other comorbidities at very less age. What are the contraindications of bariatric surgery? If the age of patient is less than 16 years of age or more than 65 years of age, bariatric surgery is contraindicated, and the absolute contraindication is Prader-Willi syndrome. Because of hyperphagia, the patient will gain weight again even if we do surgery. And other contraindications are in psychiatric patients. Let's know about the bariatric surgeries. Bariatric surgeries is of two types: restrictive type, malabsorptive type. In restrictive type, they restrict the amount of food entering the stomach, so thereby the patient will get early satiety, and the patient will eat less food. But this method is not good for excessive sweet eaters. Whereas in malabsorptive type, for a larger portion of intestine, the food is not even exposed. So food particles are not digested and absorbed. So there will be malabsorption, thereby causing weight loss. Coming to classification of bariatric surgeries. Bariatric surgery, it might be restrictive type or malabsorptive type. And some of the procedures may have both restrictive action and malabsorptive action. In restrictive type, we have sleeve gastrectomy, LAGB, that is laparoscopic adjustable gastric banding RYGB, that is Roux-en-Y gastric bypass. Other thing is OAGB, one anastomotic gastric bypass. Last one is intragastric balloon. These bariatric surgeries, it might be done as an open procedure or as a laparoscopic procedure. Laparoscopic procedure is preferred as it decreases the length of hospital stay and patient get to his work soon, and there is faster wound healing, and there is low surgical stress. By all these reasons, laparoscopic method is preferred over open method. In malabsorptive type, we have BPD, biliopancreatic diversion surgery. The other thing is BPD with duodenal switch. And the third thing is SIDIS, that is single anastomosis, duodenal-ileostomy with sleeve gastrectomy. During postoperative period, most of these patients, especially after malabsorptive type of bariatric surgery, they will develop a deficiency of fat soluble vitamins and iron deficiency anemia, B12 deficiency anemia, and osteoporosis, which is why postoperative nutrition supplementation is very essential in these patients, which is why we need to supplement these patients with multivitamins, oral iron, oral vitamin B12, and vitamin A, D, K. So let's know about sleeve gastrectomy. In sleeve gastrectomy, using linear stapler, we will cut a large part of stomach along the greater curvature. This is an image showing sleeve gastrectomy where a large part of stomach is cut using linear stapler, that is along the greater curvature. This is most commonly performed bariatric surgery, and it is relatively safe, rapid to perform, and there are relatively less complications related to this. And weight loss occurs by two methods. One is by restriction of food. Since the capacity of stomach is reduced, there will be less food entering stomach, thereby causing early satiety. And the other method is by hormones. Gastric fundus releases ghrelin, which causes hunger and causes the patient to eat more. In sleeve gastrectomy, we are resecting a large part of stomach, so there is no ghrelin at all, there will be decreased amount of ghrelin, so there will be decreased hunger. So by these two methods, there is increased weight loss in sleeve gastrectomy. Now let's know about LAGB, that is laparoscopic adjustable gastric banding. In LAGB, we use pars flaccida technique. That is, we approach stomach through lesser omentum. In this image, on the lesser curvature of stomach, we will have lesser omentum. We will select an avascular plane and we will enter via that plane. This is called pars flaccida technique. In this technique, we will use a gastric band. We will place it just below gastroesophageal junction. If this is GE junction, just below GE junction, we will place a gastric band. This is adjustable and it has a port which is placed just beneath the skin. By using the port, we can inflate the gastric band or deflate it. This is the most safest bariatric surgery, and this is reversible surgery. After placing a gastric band just below GE junction, we will do gastrogastric tunneling. That is, we'll approach the stomach by gastrogastric suturing, so that this band won't be dislodged up or down. Then advantage of LAGB are: 1. This is safer procedure. 2. This is reversible. 3. There are no nutritional deficits occurring because of this procedure. And we are not cutting any stomach or intestine, so there are no chances of anastomotic leak, and this is relatively safer procedure. And regarding disadvantages, this band will cause foreign body sensation for the patient. It will cause a lot of discomfort. And number 2, after this procedure, the patient needs to be so committed to it. Otherwise, he may cheat and this procedure won't be helpful to him. So it needs more commitment. Now let's discuss about Roux-en-Y gastric bypass. In Roux-en-Y gastric bypass, first we'll separate the stomach via linear stapler. As shown in the figure, we'll create small gastric pouch and large distal pouch. And in Roux-en-Y gastric bypass, we are cutting stomach, linear stapler, and we are cutting jejunum, and we are doing gastrojejunostomy and jejunojejunostomy. So after cutting jejunum, the distal segment or the roux limb is anastomosed to proximal gastric pouch. So this is roux limb, and this is biliopancreatic limb or Y limb. Through all this segment, bile juice is entering from biliopancreatic limb to common limb. Food particles are coming from proximal pouch of the stomach, from roux limb, and then entering into common limb. Here food is bypassing biliopancreatic limb, so there is no so in this portion there will be no digestion at all, and there will be no absorption. So this is both restrictive procedure and malabsorptive procedure. This is restrictive procedure because a large part of stomach is being bypassed, and this is malabsorptive procedure because food is entering into jejunum directly and bypassing duodenum and proximal part of jejunum. So these both restrictive and malabsorptive and primarily restrictive. Now let's know about one anastomotic gastric bypass. This is also called mini gastric bypass. Compared to Roux-en-Y gastric bypass, where we are doing two anastomies, that is, we are doing gastrojejunostomy and jejunojejunostomy. But in mini gastric bypass, we are doing only single anastomos, only one anastomos, which is why the name one anastomotic gastric bypass. That anastomos is GJ. As you can see in the figure, with linear stapler, we are dividing the stomach, creating a small gastric pouch, and we are anastomosing that end of the pouch with jejunum. That is, we are doing gastrojejunostomy. This is also both restrictive and malabsorptive type, where it is mostly causing restrictive type. It causes weight loss by both restrictive manner and malabsorptive manner. More of restrictive type. Now let's discuss about BPD, that is biliopancreatic diversion. This is also called scopinerve surgery. So let's think that this is stomach, this small bowel, and small bowel ending in large bowel. This is IC junction. Biliopancreatic diversion, we are cutting ileum. We are doing distal gastrectomy. So we are doing distal gastrectomy. We are doing gastroileostomy and ileoileostomy. After this, it may look like this. Small gastric pouch. This is duodenum, jejunum and ileum. This is biliopancreatic limb, and we have roux limb. This is biliopancreatic limb shown in green color, whereas this pink color, this is roux limb, and this radium color, this is common limb. In scopinerve surgery, the roux limb is approximately 2 meters and common limb is 50 to 100 centimeters. That is, the food we ate comes via roux limb into common limb. For a large portion, the food is not even exposed to bile and pancreatic juices, so there will be malabsorption, which is why biliopancreatic diversion surgery is associated with maximum weight loss. It is also surgery with maximum morbidity and mortality. When we ate food, the food from stomach reaches duodenum. From duodenum, there will be negative feedback for the stomach to decrease acid secretion. But as you can see here, we have done distal gastrectomy and acid is not at all reaching duodenum. So there will be no negative feedback. So as you can see in this image, if this is duodenum, this will inhibit acid secretion. Since as you can see, after biliopancreatic diversion, duodenum is not getting exposed to acid, so there will be no negative feedback. So stomach will keep on producing more acid. This causes ulceration of anastomotic limb and marginal ulcers. Since most of the food is entering common limb without any digestion, there will be fat malabsorption leading to steatorrhea. prevent these complications, we have developed biliopancreatic diversions with duodenal switch. As you can see in this figure, we have done sleeve gastrectomy. BPD with duodenal switch is almost similar to BPD with few exceptions. That is, instead of doing distal gastrectomy, we are doing sleeve gastrectomy here. Then, instead of dividing at stomach and duodenal junction, we are dividing at D1 and D2, so that we are leaving D1 part along with the stomach. So if you think this is stomach, this is duodenum, jejunum and ileum. Sleeve gastrectomy, and we are dividing at D1 D2 junction. After the surgery, it may look like this. So we have D1 here. So food will be reaching duodenum. So we will have negative feedback to decrease acid secretion. And this will be D2. And rest is similar. Duodenum will be anastomosed to ileum. And we have ileoileostomy. So what do we have here? We have done sleeve gastrectomy, and this is duodenoileostomy, and this is ileoileostomy. So we have done sleeve gastrectomy, duodenoileostomy plus ileoileostomy. So what are the advantages compared to what are the advantages of duodenal switch compared to just BPD? We are having less amount of marginal ulcers. Number one. Number two, since we are having a longer common channel compared to traditional BPD. In traditional BPD, we are having 50 to 100 centimeters. But in BPD with duodenal switch, we are having 75 to 125 centimeters, a slightly longer common channel. So there is the weight loss will be less compared to BPD, and there will be less amount of steatorrhea, and there are less risk of dumping syndrome. Coming to SADIS, that is single anastomotic duodeno-ileal bypass with sleeve gastrectomy. So in biliopancreatic diversion with duodenal switch, we are doing two anastomos. But in this surgery, there will be only single anastomos. So what is the advantage compared to BPD with duodenal switch? There will be single anastomosis. So surgical trauma will be less. So there will be increased recovery compared to that, and less complications. So what are we doing in this surgery? So if this is stomach, duodenum, jejunum and ileum is large bowel, we are doing sleeve gastrectomy. And instead of creating roux limb and biliopancreatic limb, we are directly anastomosing ileum with that remaining gastric pouch. So it may look like this. we are having only gastroileostomy. So in single anastomotic duodenal bypass, single anastomotic duodenal bypass, we are doing first sleeve gastrectomy. Then, instead of creating roux limb and biliopancreatic limb, we are anastomosing ileum with duodenum directly, which is why it is called duodenal bypass. So the resultant anatomy may look like this. So we are doing duodenal bypass. So this portion of gut will act as a malabsorptive part, because food will enter from here to here, and it will enter out via common limb. This green shaded portion is being bypassed. The advantage of this thing is there is only single anastomosis, so there will be less perioperative complications. So let's know about intragastric balloon. This is endoscopic procedure. This is restrictive type. See, in this surgery, from mouth into the stomach, we will pass a deflated silicone bag. So via endoscope, we are passing deflated silicone bag, and then we are filling it with water. This is silicone bag. And then we are filling it with water. So a large portion of stomach is being occupied by this intragastric balloon. So there will be early satiety, early gastric filling. So by restricted type, it will cause weight loss. And this intragastric balloon should be removed after 6 months. Now let's know about endobarrier liner system. This is also endoscopic procedure. This is malabsorptive type. In this surgery, through endoscope from mouth, we are passing a liner into duodenum and proximal jejunum. So if you think this is the liner, it is firmly adherent to the luminal wall, and it is till proximal jejunum. It acts like a barrier so that food won't be absorbed in this segment wherever the liner is placed. So if you think this is food will come here, gets partially digested in stomach, enters via this liner system, completely goes out without digestion. So this is a malabsorptive type of surgery, and this is also removed after 6 months. Coming to complications of bariatric surgery. Most common early complication causing death in these patients after surgery is pulmonary thromboembolism, which is occurring due to DVT. Early complications means occurring within 30 days. And the most common immediate complication which is causing death is anastomotic leak, which is causing peritonitis. Coming to sleeve gastrectomy, the early complications are leakage at angle of his, which is also called Achilles heel. As you can see in this image, we're applying staples as shown in the figure, and near this angle of his, at this area there is increased chances of leak. So this is called Achilles heel of this surgery. If leak happens from here, it will take so long to heal, and it may also cause bleeding, and it may also cause deep vein thrombosis followed by pulmonary embolism. Late complications include gastroesophageal reflux disease and weight gain. For lap adjustable gastric bypass, it may cause port site infection. We have inserted a subcutaneous port in these patients so that we can adjust the pressure of gastric band. So it may get infected and it may cause port site infection. And the second early complication include deep vein thrombosis and pulmonary thromboembolism. Late complications include gastric erosion. Because of the continuous pressure by the band on the stomach, it may cause gastric erosion, and if this sustains, it may cause necrosis of that area followed by perforation also, and it may also cause weight gain. For Roux-en-Y gastric bypass, we are doing in Roux-en-Y gastric bypass we are doing two anastomos, which if properly not anastomos, it may get lead to anastomotic leak, and there might be any bleeding, and at the anastomotic site it may get obstructed. It may also cause deep vein thrombosis and pulmonary embolism. Late complications include Peterson hernia, and because of extensive manipulation, adhesions may form, and this may also cause weight gain. Thank you.